to his name. Sir.
Thank you, friends, for being here. And at least few people are there. So I'm not going to take a difficult topic as Dr. Shubda was taking and Dr. Shamik has taken. I am going to take a very simple topic, but little difficult to do unless you are well prepared for it. Okay? So discussing about चल क्यों नहीं रहा slide? Slide नहीं down. Very quickly, 13-year-old assigned male at birth, presented with vague abdominal pain, academic decline, and social withdrawal. On some questioning, child expressed a desire to be seen as a girl. Okay, not very uncommon, I would say. We may find such scenarios in our clinical practice. When a young adolescent hints at discomfort with their gender, what would be your first response as a pediatrician? Okay, that we shall try to learn today. And would you explore the topic directly or wait for the child to bring it up again? Do we talk about it? In health screening and many sessions we take, adolescent mental health, do we raise this issue? Dr. Shubda is saying no. We do not generally talk about it, okay? And how comfortable do you feel dealing with this patient? ये तो जरूर बताएं लोग. Are we comfortable dealing with such children? No. Okay, let us see. So friends, we shall be defining basic terminology and try to understand some child development related to gender expression and review the provisions of gender affirming medical care and some provision of gender affirming care in terms of medical and surgical transition. Okay, very quickly we shall do it. The first thing is defining basic terminology, and let me pass it on. So this is a very, very important picture or diagram or whatever you say, which includes gender identity, gender expression, sex assigned at birth, and our romantic attractions. Taking just one by one. So gender identity is our own sense of feeling, that how do I feel? If my sex assigned at birth was male, do I feel like a male or do I feel like a female? Okay. So gender identity is a self-identity. It is not given by anyone else. It is my own feeling. How do I feel about it? Right? Remember it, this is gender identity. Gender expression is how do I express my identity? So if I am feeling as a male, wearing a tie, coat and pant and this thing, so I am expressing my identity as a male. Right? What if I wear a sari with mustache and all the beard? In some conferences you might have found such people, such a person also. So what do you feel that then? So maybe I am male, assigned male at birth, but now I feel I am a female. Okay, so gender expression is how do I express, and it is very much cultural also. If you go to Scotland, there are men wearing skirts, but that is acceptable there. Okay, so your expression depends what do you want to express, how do you want to express, and depending on the cultural issue. I am aware of one biostatistician. In some conference, people found him as a male. He's a male assigned as sex male at birth. And in some conference, people found him as a female, dressed as a female. Okay? So this is gender expression. This is very clear. It is the pediatrician who assigns sex at birth. Is it? Or a gynecologist? Or who has the privilege of telling boy or a girl? It depends in the situation. Mostly it is a pediatrician. So this is very clear to all of us. Sometimes we are not able to assign a sex. So intersex is much different than transgender and other conditions. Okay? This is a physical thing where the other persons are finding it difficult to assign the sex. And romantic attractions are absolutely different things. So irrespective of my gender identity, irrespective of my gender expression or sex assigned at birth, My romantic attractions, physical and emotional, may be same or may be different. Okay? So this is a word where many things can happen and not everything is very well defined. Okay? It may happen that you know about most of the things, but you may encounter a person which is entirely different than the others. Okay. So various terminologies are there. Even Tamil Nadu government has one act which includes these terminologies. We should be very well aware of these various terminologies. People are known in various communities in various languages. Okay. So understanding the child development in terms of gender identity and expression. So at what age this gender identity is realized? Can someone tell me? Any idea? 3 years. Okay, you are very much right. So understanding of gender happens definitely before adolescence. Definitely before adolescence. Okay, or before puberty begins. I met one transgender whose assigned sex at birth was male, then that converted to female in Australian Royal Children's Hospital. That lady or girl, I can say now, was very much annoyed with pediatrician. She said that had my pediatrician knew this thing and identified my gender identity before puberty, so maybe something could have been done and my voice could not become like a male. Okay, you can do all operations, but very difficult to change your voice. But before puberty, do those things, maybe voice can also be managed. So it is the pediatrician who must recognize and act before puberty begins. We are talking about pre-puberty care. Okay? So this is a very, very important thing we should identify and offer the care. So at about age 3 and age 4, stable sense of gender identity develops. Age 6, 7, gender diverse may start to feel social anxiety. Is so much early in the age. Okay? They will start noticing body changes. If gender diverse, may start considering social transition also. But very difficult things are there. And adolescents, definitely they know what is to be done. Right? Okay. A word about gender dysphoria. This is the distress, a definite distress of being a different person and not able to transition, not able to get recognition, not able to get support. And whose support is most important? Parents. Okay, I met several of transgender people in various programs, and they say that if we get support of my parents, then I can fight with the world. But parents का support बहुत ज़रूरी है. And pediatricians are the people who can garner this support for such a child. Okay? So we have a great responsibility. So this is a discomfort or distress at being treated as assigned gender at birth, but the person feels differently now. It is very difficult in society to get respect for the identity or gender identity which is different than the sex assigned at birth. So these people certainly need lots of support from family, from society, and especially from a pediatrician. Okay? And pediatrician can be a person who can guide family for adequate support. So, a 14-year-old assigned female at birth discloses identifying as a non-binary or other gender during an anonymous screening questionnaire. They are not ready to discuss with the parents. Here, I am using the word they. So English language has very few gender neutral terms. So they is used for an individual person, single person. Okay. But in Hindi, wo, main, there are many words which are gender neutral, but our verbs are not gender neutral. So in different languages, we need to find how to describe those things. then what should we be doing if we find that in our screening questionnaire, this disclosure comes to us? So we need to learn how to deal with such situation, and with all those qualities of an adolescent physician or a good doctor, being compassionate, being non-judgmental, doing ethical things, and taking help of others if you are not comfortable, we can deal with these situations. Okay, so clinician must affirm the adolescent's gender identity, provide supportive counseling, and navigate confidentiality carefully while knowing local regulations about minor consent and privacy. Should we involve family in such a case or not? So we need to involve family in almost in all the cases, but we have to be very, very careful because we have expressed confidentiality to the child. We need to take this child's permission to talk to the family and prepare the family to accept such a child and support such a child. So we have an extended responsibility in such things. What are the provisions of gender affirming medical care relevant to all pediatricians? Yes. Transitioning is very, very important condition which we should remember. Transitioning means declaring this to the world that I am a transgender person. Okay? So we have to support. There may be social affirmation, medical affirmation, and legal affirmation is also there. India has a very good act about it, and various legal things are available for legal affirmation, because then you need to have change all your certificates, Aadhaar cards, and many other things. So we should realize and know how to normalize gender exploration, normalization of pronoun use. Our language should change, maintain knowledge of basic terminology, non-judgmental listening, cultural humility, respecting our patient, okay? Just not discarding. I remember one child came to our clinic, our sister told that that was a male, sex assigned male at birth, but he was talking like a female. Sister told that child, ठीक से खड़ा रहे, ठीक से बात नहीं कर सकता क्या? It was a very incorrect thing. Okay, this child never came back. So we have to respect our patients. So many things are there. I am not intended to discuss each and everything. We need to learn about it, about the terminologies which we use with these patients or clients. So we need to create an affirming clinical environment, and we need to ask, how should I know you? How should I identify you? And whatever the client says, we need to remember and we need to accept it. Okay, so that is very important thing. And this is a real thing. Ask me about my pronouns. Okay, in many of the sessions, what I found in one of the sessions, Dr. Sonia, disability, etc., was being discussed. So the speaker describes himself. I'm a male person wearing specs, wearing a blue color tie and suit and pant and shirt, and my pronouns are he and him. So the person who is visually handicapped, the person who has some hearing issues or something, so then you have to describe yourself and declare your pronouns yourself. In many of those Zoom meetings, you will find even I use sometimes my pronouns. So you have to declare your pronouns. Okay? Nobody can judge you just by your appearance. So that is the thing we should realize. In creating gender affirming clinical experiences, so whatever patient we are getting, we need not to examine in so much many details. In general also, we do not do those private examinations unless it is very much ready-made. So that is true for these patients also. So we need to encourage family support and other social support. Early intervention is very, very important, and we can reduce gender dysphoria and treat gender dysphoria very well. And we have several such standards available from Bird Association, from Indian Association, and our own guidelines are there. So if you want to read these guidelines, these are AHA guidelines about the subject. And you can, if you scan this thing, you can get that article. I will again put that QR code in the last slide, so don't worry about it. So in 23, we have come out with these guidelines which describes all these things in Indian context. And now I invite Dr. Sonia Taneja, who is an assistant professor, please come, of pediatrics in Boston Children's Hospital, Harvard Medical School, and she has some experience of treating such patient, dealing with such patient. She will describe about this thing quickly.
Thank you so much. Okay. Hi, everyone. Thank you so much, Dr. Pemde, for having me contribute to this presentation. So I have seen and kind of done some work in gender-affirming care in the US at Boston Children's Hospital, so I thought it might be interesting for the audience to share a little bit about what we do. So I'll give you an example. So if I'm introducing myself as Dr. Sonia, I would say my pronouns are she, her, and I am an ally of transgender youth, and so I think that's also very important to always discuss. And so the first thing I'll discuss is around the first thing, sort of first step for youth can actually be around their Tanner staging of 2 to 4. As Dr. Pemde mentioned, many examples of this. It's quite distressing. It causes gender dysphoria to develop the secondary sexual characteristics of a gender identity that you don't identify with. And so in order to stop that, we provide these gonadotropin-releasing hormone agonists. So instead of the pulsatile GnRH secretion that normally sort of teenagers may experience, we actually provide these agonists, which stops that pulsatile secretion. And so in general, the goal is to start it early before they start developing these characteristics, and it sort of hits the pause button on puberty. And so what does that do? That prevents those secondary sexual characteristics. And I think the biggest question we get from practitioners and also from parents is this a permanent thing? Is this going to permanently change the downstream effects? And the answer is no, this is entirely reversible. And so as we kind of discussed in the beginning of this presentation, gender identity can be fluid, it can be ever-changing. I think youth who kind of identify themselves and start beginning their stable gender identity can also change over time, and that's okay. We should take cues from our patients, and so this gives them more time to sort of develop that understanding for themselves. Of course, you can give masculinizing treatments when an adolescent is ready. This is, of course, typically with testosterone treatment, and our goals you can see at the bottom in terms of lab monitoring are there. Again, this is for those who wish to identify in that way. And then anticipatorily, just to mention, the reason we take some of those histories of what body parts particular youth have is so that we don't forget to continue to screen for those body parts, even if it doesn't match their individual gender identity. And we usually ask the patients how they want to be referred, they want their own body parts to be referred to, so as to not induce gender dysphoria. Similarly, for those patients for whom menstruating causes gender dysphoria, we can do menstrual management. Many transmasculine individuals are not comfortable taking pills with estrogen, so typically this is done with progesterone-only pills. Other options include intrauterine devices or other sort of longer-acting reproductive tools like the Nexplanon, the arm implant. Again, we would always want to counsel against those who have higher risk for blood clots, just to kind of put that out there. Feminizing treatments include exogenous estrogen as well as anti-androgen medications, largely with spironolactone. Similarly, we want to counsel against particular risks, but often these medications are quite safe, and that's, I just wanted to kind of mention, there is a study that compared the suicide risk of someone who's experiencing gender dysphoria, unable to access medications like this, and then the risk of mortality from blood clots, and the risk of suicide is much, much higher. So I think when there's fear around prescribing these medications for people thinking it's not helpful, it actually is quite helpful in preventing mortality from suicide, if you think about it in that way. Other sort of devices that I think, children will get information from the internet before asking their physician anything. So something that we can do as practitioners, and we do at Boston Children's Hospital, the gender clinic there, is also give safe advice on how to start presenting socially. in their preferred gender identity. So you want them to get the information from a safe place like a physician's office and not maybe on the internet, because that can be more harmful. So information on tucking, for example, for trans feminine individuals, binding for trans masculine individuals, and then these stand to pee devices for trans masculine individuals as well. These are surgical therapies that, of course, I won't go into, and of course, I do not practice myself, but of course, we refer out to our colleagues. Top surgeries, bottom surgeries. I wanted to mention Nirvan. This is, I've done a lot of research with the Hijra community in India, and the Nirvan is a very common sort of procedure that happens external to the formal medical environment. And I think we should know about it as pediatricians, because you may find patients, and I've seen patients who've presented after getting this procedure and with some complications. And so, of course, providing guidance around this is very helpful. Vocal cord surgery and facial feminization surgery. Facial feminization surgery is actually something that trans feminine individuals actually desire even more often than top surgery or bottom surgery, because it is sort of changes how the world sort of perceives them. And so that's something that is very helpful to them in terms of, even more so I think than top and bottom surgery is often, in terms of not experiencing the discrimination that they often face in society. Other relevant care, hair removal, fertility preservation I wanted to bring up because it's something that's very new in the United States as well, and it's something that I hope that all people will be able to access at some point, how to think about cryopreservation of tissue at the time of bottom surgeries in order to make sure that that person can still access fertility in the future if that's their desire. Something that I also really wanted to bring up, parents and physicians, of course, have always have this question. This is a big political topic in the United States right now. I would be happy to speak to you about it afterwards, about do people regret this? Do youth regret this? Are parents regretful of this? There was a wonderful paper that came out in JAMA Pediatrics last year that studied 200 youth and their parents receiving treatment with puberty blockers or hormones, and the level of regret was very low. A more quantitative measure of that was how often did people continue with this treatment rather than stop it. That sort of percentage was quite high. And then asking them in terms of do they regret this treatment was also very low. This is also true for surgical treatments. So surgical treatments, the level of regret for getting a gender-affirming surgical intervention is also very low. It's lower than other surgeries that we do for other kind of non-gender affirming reasons. Like, I don't remember the exact surgeries they were talking about, but sort of this is all sort of speaking with general surgeons and their patients. It's about less than 1%. So I think this is sort of a rule and sort of something we can take away, that we should trust our patients and trust the family members. So similarly, something I always like to tell patient parents, because no matter where you are, parent acceptance and approval and being there for their children is such an important predictor of resilience for these patients, that we need to be the ones to help bring in the parents into some of these discussions and their care. So encouraging all of this. So making sure to always advocate for your patient, but not making the parents like alienated from that discussion is very important. So these are some discussion questions. I know that we're short on time, so if you wanted to discuss, we can do so. And then these are all of the people who contributed to this presentation and the QR code for the guidelines that Dr. Pemde mentioned.
Any questions or comments, we'll be happy to answer.
When is surgery done for these children? When are they taken up?
Surgery.
At what age?
Such a good question. So for surgical interventions, it is an ever-changing limit actually right now in the United States, because there's a lot of cracking down on sort of gender-affirming care in a lot of spaces with the new administration, so it's ever moving. The youngest it's always with parent, consent that it's done for anyone who's below the age of 18, and I believe the youngest is about 16.
In India, it is beyond 18 years.
Yeah.
Beyond 18 years. Because beyond 18 only you can give consent. Consent of the person is very much important. Beyond 18, parental consent does not matter. Then it is not done before 18. Temporary temporary things you can do before 18, but permanent things you do always after 18.